Dr. Abhay Uppe. I still cannot believe that this has happened. He is someone who all of us, anyone who knew him even remotely, would remember very fondly. He was full of energy, contagious childlike excitement, and eager to learn and do things, whether new or old alike. I was very fortunate that I happened to be his student and learn from him all through my postgraduate days. I've very closely seen his undying passion for pulmonology, his ability to empathize with the patients and their families alike. Forever, Dr. Abhay would remain a towering figure in the field of pulmonology, especially for all his students and patients. You are and always will be dearly missed, sir. And I'm also certain that your accomplishments will continue to exemplify the very best in science. On behalf of the CCI family, I would really like to extend my condolences, our deepest condolences, to all his family and friends. And I would only like to say that there is nothing that will be able to fill the void that has been created in your lives and ours.
Uh, Good evening, all. Really, very much unfortunate and with heavy heart, we all have to accept that our beloved Dr. Abhay Uppe sir, he is no more amongst us, and we all CCI members over here definitely do miss him. And this space, this empty space, is definitely not going to be filled very easily. Would ask each and every member over here to just remember him in each and every prayers. Obviously, he is there, he is with us, and it's not about missing him. He is there along with us right now, and I'm sure he is present in this. He's going to be present over here and going to bless us in this webinar also. So this is the first webinar after his uh, heavenly adopt. So we have come up today with a presentation, which I would say, which is somewhere really, had an impact in with his life also, because he was a person who was a co-investigator for a very big national ongoing trial right now. That is the national BPAL trial, modified BPAL trial, which is going on in India. And we were the first one to start this trial in India. And trust me, he was a person who had, because without whom ethical committee clearance at our state, our city wouldn't have been possible. He was the one who connected us with the ethical committee, and he was one of our co-PI where we had started this trial in India, and we were the first in India to start this trial. So Dr. Abhay Uppe is also one of the practitioners who is deeply involved in this NTEP and treating tuberculosis. And he was one of the example of our private-public partnership model. He was a person who was a private chest physician, but was also engaged equally and devoting his time for NTEP program, that is the public trials and the public program. So definitely we are going to miss him. And yes, this program, finally, that is NTEP program, goal set for 2025, TB-free India. Whether are we able to achieve this program only along with public sector, or whether we as the private chest physicians are going to make some impact or make some difference in eliminating this program. So yes, this is all discussion going to happen very soon. And we have an eminent panelist over here. We have a fantastic team today. Trust me for this. That is, we have our own Dr. Anuj Bhatnagar, sir. Dr. Anuj Bhatnagar, who we all know him very well. There is no need to introduce him, to be very frank. Dr. Anuj Bhatnagar, K. Bhatnagar, who is a consultant chest specialist and head of department, from RBI PMT, that is Delhi, and Rajan Baba Institute, that is Pulmonary Medicine Department. And he is also the National Technical Expert of India and one of our close friend who is an expert for making a guidelines of India for PMDT guidelines. So he is one of the member amongst us. Next, along with us, we have Dr. Narayana Pradeepa. Again, Narayana Pradeepa, very close to our, a very good friend of our, the founder, secretary, trustee of CCI, and a chest physician who is working in the district of Kasaragod, that is Kerala. A fantastic person, very passionate for working in this field of tuberculosis, Dr. Narayana Pradeepa. Next is Dr. Anil Maske, a very lovely friend of ours, and you can say a favorite of all CCI members, and a Google of all our CCI members. Whatever problem we have, any contact person or any contacts needed, he is a person who is working, like in the backend team. Associate Professor of Respiratory Medicine, that is SRTR GMC, that is Ambajogai in Maharashtra, and a General Secretary of Chest Council of India. Next, we also have a very senior person, Professor Thomas Vadakkan sir, Department of DM Pulmonary Medicine at Amala Institute of Medical Science, that is Thrissur. I welcome you, sir, over here. And we have Dr. Radha Munje madam. Now, whatever I tell about Dr. Radha Munje will be really less, as one of the star person, a star in our CCI group, who is very much active day in, day out. Everyone knows her. Whenever there is any question, we immediately get replies from her. That is Dr. Radha Munje ma'am, who is working at Nagpur, a PG guide of all chest physicians, of many of the chest physicians, DDCD as well as MD chest physician, president of Vidarbha Chest Association, and has been a faculty of n number of conferences, chairperson of Ethics Committee, GMC, that is National Institute of Miners Health, that is AIMS Nagpur. And I welcome you, ma'am, over here. Very much fortunate. The great thing is, in this webinar, we are going to also meet, we have some guests over here today, Dr. Malik Parmar. Dr. Malik Parmar, one of the national faculty, who is going to be along with us very soon. I'll introduce you whenever he joins us over here, because he deserves the introduction. And also one of the guests, Dr. Shibu Balakrishnan, who will be joining us very soon. So with this, Dr. Shibu Balakrishnan is already over here. So he is one of our national faculty and a national figure who like trust me for this, and I wouldn't deny this. One of the mentor for Dr. Vikas Oswal would be Dr. Shibu Balakrishnan. I remember 11 years back when I had gone for a PMD training as a private chest physician. And this was the journey, I would say, a journey of my field in tuberculosis. And one of the teacher whom I met first was Dr. Shibu Balakrishnan. And I'm really thankful to you, sir, over here. You accepted our invitation. And today you are over here for the topic, this PPP model. And I'm really thankful to you, sir, for joining us over here. So I have a small presentation over here to make about this PPP model, and would just like to elaborate a bit in brief and very fast, because this is one of the model which we are following over here in Mumbai. Is my screen visible? Yeah. Thank you. So Dr. Vikas Oswal, myself, Dr. Vikas Oswal, a private chest consultant and working in 2 DRTB sites in Mumbai, plus a national technical expert member, one of the member for making of the national PMDT guidelines. So why this private and public partnership, is it really essential? Yes, I would say it is essential. Only public sector alone cannot fight this battle. Only private sector alone cannot tackle this war. If we really need to win this war, we need to have the joint effort of all the sectors, not only private, not only public, But I would say each and every stalwarts working in a field of TB need to join hands together if we really need to eliminate tuberculosis. But still, we see there is a lack of collaboration in many of the cities, many of the states in India right now. What is the hurdle going on? Where the problem lies is everything we are going to discuss today in our webinar. Private issues, private sector issues are diagnosis. We all know TB gets, there is a lot of delay in diagnosis of tuberculosis. We need to diagnose TB at the earliest so that we tackle this problem at the earliest. The turnaround time needs to go down further, right from the seeing of the patient till offering him the medication, diagnosing him and offering him medication. This TAT needs to go down with the joint efforts of everyone. Treatment, we all know bringing in public sector, private sector only, it's a big challenge for us because the newer drugs are, we hardly have any hands on newer drugs right now. Whether is it good or bad, let us just discuss later on very soon. The follow-ups, we many times miss to, lost to follow-up of the patients because we don't have ample of time. Being a busy practitioners, it is very much difficult for each one of us to maintain a record of each and every patient. We just examine our patient who is sitting in front of us, believing that yes, this particular patient is going to visit and come back to me after a month. A monthly follow-up is very much important, as we all know, but whether we are able to keep a record of this follow-up or no is a big question mark. We have to ask ourselves whether do we really call each and every patient or do we really have a track of each and every patient right from diagnosis till the cure rate, till the outcome. That is very important. Rising risk of DRTB. There are a lot of many DRTB cases, at least in Mumbai, what we see is primary DRTB, never exposed to TB bacilli in past, never exposed to any TB drugs in past, no even family history of tuberculosis many times. Still the patient is coming up with a primary DRTB. So yes, drug regimens, there are multiple drug regimens in the field, floating out in the field. Many permutation and combinations of the drugs has been given. We are not adhering to the guidelines. Probably these are some of the problems, which we need to tackle very soon. Transmission, it spreads very fast, as we all know. Awareness is lacking right now in the field. We need to do something for awareing people, to create a lot of awareness in people. The way COVID-19, right now, if you ask even a 3-year-old child, he might be or she might be, the child might be able to tell us that, COVID se bachna hai, covering your face or just washing your hands, wearing a mask. That 3-year-old child, before leaving his house, he automatically by default covers his face with mask. Why? Because awareness was being created. There was a lot of noise in the field. We need to create similar noise and similar awareness need to happen for tuberculosis also. Rather, this should have been done before. We would have been able to tackle COVID very easily sooner if there would have been awareness in the field. Burden on the patient, very high expense. We all know our patients coming in private sector, we all counsel our patient, but somewhere we fail in one small counseling. That is the informing them about the duration of the treatment and the cost involved in the duration of treatment. I don't mean that we are hiding them purposefully, but we are missing over here. Maybe subconsciously, we are failing to inform them the number of pills he's going to purchase, the number of days he's going to consume those pills, and calculate the number of expenses or the expenditures of the total treatment, not only of 1 day, 1 week, or 1 month. We need to give the information about the total treatment expenditures and then let him take a choice of sticking only to private sector, or he needs and support, external support from a private public sector or no. So we need to give them a complete information that is very important. For how do we tackle all this? There are a number of schemes which have been floating around by the government. Still we are failing. Reason, mistrust, regimen. Regimen has been interrupted a number of times because of the lack of the sustainability or the availability of the drugs. Sometimes the logistical issues, the drugs fail to reach the particular center. Mistrust. Government patient coming to the private sector, we just tell them, oh, it's okay, just cross this prescription and give a new one. Same happens in the government sector also many times. private sector prescription coming over there, don't even bother to see if the regimen is right or wrong. Maybe just, subconsciously, maybe not purposefully, but we just cancel off the prescription and making a new regimen. There's somewhere this mistrust between, or the attitude amongst the private and public sector need to be breached now. This trust needs to be developed in both the sectors. That is very important. And the first step, because patient is watching everything. Patient is clever enough and make a false judgment that probably public sector had made a mistake, and so the private consultant had cancelled the prescription and made a new one. Rather, if the words would have come from our mouth that, okay, this particular regimen is right, but we need to maybe add something or subtract something or guide him in an appropriate way, probably the trust wouldn't have breached over there. Patient would have felt, okay, I have again come to a safer hands. I was in a safer hands, but I have come to a better person and a better hands right now. Maybe somewhere this trust needs to be developed, and it is going to happen only when both these sectors join together and work together. Patient retention, we all agree. We are waiting over here. Forget about private and public. I would say even private and private. Patient does number of window shopping. We all know that. Patient comes over here. Patient take a prescription from us. He takes a second opinion from some other, but goes to third and gives his opinion to the fourth one, that these are the particular prescriptions given to me by 1, 2, 3, 4, doctors. So patient is somewhere, we all know this practice of patient, but still we need to retain our patient, and that will happen only when there is a proper channel guidance for the patient and proper counseling that this is a particular disease you are having. This is the only sector from where we're going to get medication. This is the place from where your burden is going to be reduced, maybe in the form of, say, investigations or the pills or the ADR. We will take care of you and you will be, out of this disease very soon. So small counseling, very important. Payment, a significant delay in not only to why when there are a number of schemes, still the payments, many times the payment don't reach to the NGOs. For how long the NGOs would work free of cost? Sometimes even they need, a proper payment at time. That is very important, because they are working with no profit, no loss model. And on that, but still they had to pay wages to their staff, which they have appointed only for the betterment of the TB patients in the field. So somewhere the payment to be released to NGOs should be on time. That is very important. Maybe there is a delay in the payment from, say, any sectors, but this delay somewhere do cause a lot of interruptions in the treatment. Capacity. We need to build up and engage more and more private sectors for capacity building. So these are some of the points where we are going to discuss over here today in this webinar, whether after touching each and every point, or rather, one model doesn't fit to every state, every model. We need to have different models as per the city and as per the state, because there won't be specialists, chest physicians available in a remote area sometimes. So the model over there would be different. Similarly, a different model would be, there would be a number of models. So we need to, just listen to the experiences of the speakers over here today, available over here, so that we come up with something good. There were a number of publications which were being made that these PPP model are really successful if being taken care and a timely interventions has been done. One of the models from the Ujjain district, the PPP model had shown a very good improvement. But the only thing is, only private and public models won't work. We need to have an NGO, taking care of both the sectors, private and public, and working around together, because only public sector don't have that much of patience or HR, payment is less, availability of the staff is less. Private sectors, only private sectors, no. Money cost is really high. Drugs availability is a problem. Patient don't have, private sectors don't have only, don't have time rather. They don't have time. They have multiple chambers to attend their patient. They will just sit over there for a minute in a chamber, 5 minutes, 10 minutes, at the maximum 15 minutes per patient. But then once the patient goes out of the chamber, what happens in the field, we don't know. We don't have time to track the patient. We don't have time to, call back the patient the next month maybe. So somewhere we need an NGO who will fix up this problem so that this model of PPP, that is NGO-based private public partnership models, runs very smoothly. So the dedicated NGO takes care of both private and public, and then the journey really goes very smoothly. This was one of the small model which was started in Mumbai first in some around 2016-15 onwards, where the case notification really went up. Now, this is the publication of the Thrissur, the Ujjain model. But similarly, I would also like to show the small model which we are going around right now. We have already accepted this since 2013. There was a small place we had asked in Govandi Shatabdi Hospital, and there was a small room which we had asked for, where I, as a private chest physician, had asked the local corporator that I need some space in our M ward to work for the TB patient, because we are seeing a lot of TB patients in private sector, but there was a challenge of getting a gene expert done, diagnosing them. Daily wages was, daily wages worker. The affordability was an issue. I did not join a public sector that time because the Shiv TB hospital was the only hospital where we were admitting all the patients and then treating them as per the PMDD guidelines. So then the local corporator had approached WHO consultants, and they told that you need to get trained yourself under PMDD guidelines. So that was the first step when I had gone to Calicut, and Dr. Shibu Balakrishnan, who is available over today, who is present over here in the webinar, he was my teacher, and under his guidance, he had taught us the entire guidelines so beautifully. I had attended this complete PMDD training for good 7 days, and the journey of treating TB patients and DRTB patients started from, I would say, that day. And I'm really thankful. I'm thankful to him again for the same thing. And then the TB OPD was being started at Shatabdi Hospital. Now, initially, the thing was patient need to get admitted in the hospital. There were no ambulatory OPDs. And then when we had come again from the PMDD training, that time I understood the model of the network of the corporations, of the government sector, how they are practicing. And then we had come up with our own model over here in the local area, where as a private chest physician, you should devote a time in a public sector OPD. The premises for the public sector, that is from a BMC hospital, private chest physician devoting a time for the diagnosed patients in the field, for initiating them or taking care of the ADR in the field. And this is how the new DRTB OPD had come up, where we never admitted any patient and started seeing patients only on OPD basis. So till date, we have seen around more than 7,500 cases, more than 600 XDR cases, and 90 XDR cases still now so far from this, where hardly 1.9% of our patients had to be referred for an admission. So many of them we were just taking care of them only on OPD basis, right? So early diagnosis of DRTB was being done through gene expert upfront for all the cases. Number of cases were diagnosed really well over here. We were able to put them or initiate the patient on the second line drugs at the earliest. NGO, that is MSF, was a collaboration, was a helping partner in between the private and the public. They used to take care of the HR, and the HR, they used to make available of the HR wherever they fall difficulties. Challenges what we faced over here was healthcare workers was a challenge. We hardly got any good healthcare workers at that time. We hardly got any doctors to get engaged to this model. At patient level, there were challenges at patient level. There were challenges at community level. We got a lot of political resistance. We got challenges from the program perspective point of view that there is no such model, but still they were very much happy and they welcomed us with some new initiative which was started at Mumbai and political. So these are multiple places where we do get problem, So what this model is, once this Shatabdi model was successful, then came a time of replicating this entire model, similar model in entire Mumbai. And I am thankful to all my chest physicians in Mumbai right now who started, accepting this model where all private chest physicians of Mumbai are collaborated with MCGM for ADR clinics and even initiation of the patients on second line drugs. So I'm thankful to all the chest physicians, at least in Mumbai. We are lucky enough that we have good number of DRTB, ADR clinics and DRTB units in Mumbai right now. All 24 districts of Mumbai have ADR clinics with private chest physicians devoting their time in the public sector premises and medications from the government sectors. There is a fantastic collaboration of PPP model. These are some of the key objectives of this model. Early diagnosis, case notifications went up, microbiological confirmations, we were able to diagnose more and more cases because diagnosis was free of cost. Treatment was as per the guidelines. Free drugs, we started keeping these drugs in the pharmacy, in the medical store. Hospitals providers were being made, were multiplied, and we used to have a good treatment adherence with the help of the increased number of staff. So I won't go into detail of this model now. I would be very happy if we discuss all these points in the webinar. So this is all a short about this DRTB model, at least what we had in Govandi Shatabdi Hospital. But I'm thankful to all these NGOs. If you see, there is the government sector, the private sectors, the NGOs, all these. When all these people come together, then only such kind of model becomes successful. So without the engagement of all these sectors working together, none of the model is going to become successful. We need to have a good collaboration of all the sectors and save this particular child who is still waiting for a help in many of the remote areas where they still have to wander from the department to department, place to place, hospital to hospital to get himself diagnosed and then to start his medications. So this was a small this thing from Mumbai model, that is Shatabdi Municipal Hospital. And now I just open up this discussion with this all eminent and experienced consultants and the program officers over here and throw some light or enlighten us with some more models or some more steps or some more better we can do in society for eliminating tuberculosis from India. So yes, this was a small presentation. I know it was long, but let's try to go very fast. So I would first, like to start the, okay, is Dr. Malik Parmar sir joined over here? Not yet.
Sir, Shibu sir, you are unmute.
Yeah, Dr. Malik, he is participating in another meeting as of now, so he may be a little late or may even be unable to join, but probably I will do justice to whatever he has to discuss.
We are lucky enough to have you also over here, sir. So let us start with you only first. Let you be the batsman over here today, and lucky to have you on this platform, sir. Sir, as a program manager, national program manager, I would really like to understand that is it really that difficult to create a PPP model all over India? Since you have taken a maximum trainings for all chest physicians in India, at least in public sector, I know that. I know you have trained n number of trainers have been conducted by you. Not only that, you have taken multiple PMDD trainings for on a national level. So is it really that a big challenge to create and engage private sectors in the public sectors?
Yeah, so thank you so much, Dr. Oswal. Before I respond to that, let me thank CCI and the eminent colleagues, especially the very senior colleagues like Dr. Radha Munje, and some of my very beloved brotherly colleagues like Dr. Anuj, Dr. Pradeepa, Dr. Vikas, and many others in this forum. So I'm grateful to you and privileged. Now, let me explain whom I represent. I represent WHO, that is World Health Organization. I am a national professional officer in the World Health Organization, India Country Office. The government national program managers are not here in this meeting, I believe so. But some of the government colleagues are here, the private sector colleagues, or those who guide the government programs, like Dr. Anuj and Dr. Radha Munje are here. It did not start recently. since the beginning of RTCP, probably these people have really guided the program. Okay, with that and the greetings from WHO India, let me just try to respond to that important question you have asked, Dr. Vikas. Your question was about, is it very difficult to have a public-private partnership all across India? So let me take your own words or your own statement to answer that. You just asked us to forget about private and public in your speech. Forget about private and public. It doesn't matter where the patient goes. When we say, I ask this question to my students, what makes public public and private private? So many people have told me that it's the profit. Unfortunately, it's a wrong answer. It's the capital that determines and the government that determines what is public and what is private. But just think from the patient perspective. Is there a private patient or a public patient? No. The patient who is going to the public sector is not a public property. Right. So in the patient perspective, he goes to a hospital because that hospital or that doctor, he's his private doctor. He goes to Kasaragod district hospital to see Dr. Pradeepa, who is his private doctor. He comes to Govandi and visits you, Dr. Vikas, because you are his private doctor. So all the patients, they seek care from their private doctors, their private providers. Keep that in mind. And just let me tell you something, that the goal of the private-public partnership, as you know, is eliminating TB from India. And the objective is to have standards of TB care implemented in all the facilities by all the doctors and all the healthcare providers in India. So that's the objective. With that, my take is that it is not difficult to have a complete public-private partnership if you are patient-centric. Though we have a lot of challenges in achieving that. And I would just like to remind you is that we had the highest private notification in the TB program in India for since the beginning in 2022. That is 700,000, 7 lakhs TB patients have been notified by the private sector. That's not a small amount. Huge. And also one more thing I would just like to remind you is that the patients are not, the public sector colleagues are sometimes thinking that patients are seeking care from the private sector because they are well-to-do, they are affluent. You know, TB is a poor man's disease. Not all TB forms, but most of our pulmonary TB are a poor man's disease. And 70% of those poor men seek care from the private sector because studies have shown that 70% of TB patients seek care from the private sector. So with that, with this kind of understanding, I would say that establishing a partnership is not difficult, but the public sector has to change a lot. Private sector started changing. Public sector has changed at the national level, maybe a little bit at the state level, very little at the district level, not at all in the peripheral level. So if that happens, the public-private partnership will be a reality throughout, because anything to happen in the form of a partnership, that has to happen at the most peripheral level. So private sector has changed. And I will give more evidence for that later when we discuss this. Thank you so much, Dr. Oswal.
So first to understand, now again, coming back to same thing, ma'am, Dr. Raja Munde, madam, when we are opening this discussion of PPP, private-public partnership, as Shibu sir told right now, that if we become patient-centric, that there won't be any private sector or public sector, because obviously our one motto would be to treat patient, let wherever he be, let it be in private, let it be in public. But still today also, in this webinar also, we are having this headline of PPP mixed practice. So just to understand from you, ma'am, what do you feel when we talk about PPP model? What idea do you get? Being in a public sector right now, but still if, there is something called as PPP model, even guidelines have mentioned about PPP model. I just want to understand that what clarity do we have in our thoughts of understanding this PPP model? Can you just explain us in brief, ma'am? Radha, ma'am?
I think madam got disconnected. Yeah.
Oh,
There, but the internet was a little
No.
unstable. So can you repeat your question?
Yes. So we have a headline right now today also of PPP model over here.
Yes.
So just want to understand, when a person just think or read about something called as PPP model, just to understand from you, what do you think, ma'am, what this model is and how does it work? Like, just in short.
Yes. I would take help of what Dr. Shibu has explained and ended on a note that the public sector, is already into the program, the guidelines, the facilities. They are supposed to follow the norms, right? The private is like we are priming them to be a part of this. So once the private practitioners, I won't say these, they are all our friends and colleagues. All the private practitioners, may be specialists, super specialists, general practitioners, or even others who diagnose a case of TB, or even before diagnosing, they suspect the person to have tuberculosis. The first and foremost that we would like each of the medical practitioner to be aware about the guidelines and start following the diagnostic norms. That's the first thing. So when we talk about a PPP model, I'm sure the program is open enough and has n number of PPP models, which can be like a private practitioner who does not take anything from the program in terms of, facilities for diagnostics or even for that matter treatment, but is willing to be a part of the program by notifying each and every case, which is equally important. So because as soon as the person is notified, the program would keep a follow. Then one model is at one end is this, and the other end is you can have a practitioner who or a clinic or a hospital which is being supported by the program in all aspects. Say for diagnostics, the drugs are provided, care for ADR is provided, even advanced investigations like bronchoscopy and further processing is also provided. So all these models are, and then we can have a mix and match of anything and everything. So that is what is a PPP model. So I believe that it's like a carpet rolled out, and you can step on it at any juncture and at any time, and can walk holding the hands of your patients who are either suspects or already diagnosed as a case of TB.
Yes. So that's what I wanted to actually hear, that this PPP model, when we hear about this PPP model, it doesn't mean that, only a private consultant and a public hospital, giving the medicines. No, there is more beyond that. So, which is already in field right now. We need to just,
And I did add about the laboratories. I did not add about the X-ray facilities to which we may link.
Exactly right. So it starts right from, say, diagnosing the patient, suspecting the patient, suspecting any case of TB. Let it even be in a latent phase also now. So this IGRA also, getting an IGRA done. So there are labs which are been engaged, the private labs which have been engaged to the program, and the services are being offered to the patient. Patient don't need to go and visit the public hospital, wait in the queue, attend the OPDs. No, they can avail the services at free of cost even in the private labs. The same goes with gene expert, LPA first line, second line, MGIT culture. Not only that, once positive, the DST. So the entire algorithm which has been, where we need to send a request sitting in a private lab, but in a public sector, once the sample goes, automatically gene expert followed by LPA first line or maybe even second line in case of DRTB or maybe MGIT culture with DST. All these tests are being done free of cost, including PTE, sitting in private sector also. Patient don't need to go to public sector to avail these services. We have provisions of giving pre-treatment evaluation, a set of investigations to be done before initiating the patient on treatment for second-line drugs. We also have the provisions of doing even bronchoscopy, as ma'am has mentioned over here, in a suspect case of tuberculosis, whether there is a doubt of maybe TB or maybe pneumonia or maybe something else. You suspect tuberculosis, you do a bronchoscopy. For diagnosis, also you have many collaborations are being made, or the provisions are being made by the public sectors, where patients sitting in private sector can avail the services, the patients can avail the services at private sector. The only thing is the reimbursements are being done by the government officials or by the corporations over here. Timely, the timeline has been decided with the previously as per the MOUs. So these provisions are there. Apart from this, if the patient is sitting in the private sector, the only thing is patient need to be notified by the private sector is very important. And the patient, if it is diagnosed as DRTB, he will have to go once to the DRTB center or the DRTB unit to register him, get a PMDT number over there at the DRTB center or DRTB site. Reason being is the newer drugs right now haven't been made available at the hands of the private sectors. That is the only hitch, and we are finding some ways for it also. Maybe very soon we will come up with some model for that also. But so far, the patient only need to visit a DRTB site or the OPD only when he gets diagnosed as DRTB. If it is DSTB, still the provisions are being made where the drugs are being offered free of cost in the private sector OPDs, as well as even the medical store, the pharmacies, or even the nearby, say, even the pan stalls. Many models have accepted the pan stalls or the pan providing where they have given made them a doubtful provider. So PPP model has got an entire package of everything, has been thought of many things. Dr. Anuj Bhatnagar, sir, I would come to you over here now. Sir, you there online?
I'm there, don't worry.
Oh, sir, great having you over here, sir. Sir, I would like you to throw some light on spoke and hub model, because I'm very sure no one other than you can really explain this model in a fantastic way.
See, basically, now think of a small center. So think it can be a government center or it can be a private center, right? Now, suppose this center is having the patients, but is not having all the facilities for some specialized tests which they think are required for the patient. Normally, what in a spoke and hub model, that is actually a spoke. That model serves that peripheral institute serves as a spoke. That is connected to a central institution, which is actually this hub. This actually spoke and hub model basically is a health delivery framework. These smaller facilities refer the patient to a larger facility, which can be a public or a private. Please remember that it can be a public or a private, if suppose certain specialized tests, certain specialized investigations, or additional advice for any comorbidities or involvement of other systems are required. So effectively some more advanced care which are not available in a peripheral healthcare facility. So this can actually enhance the collaboration between the peripheral units and a central unit. Please remember, a hub and spoke model can also be there, can also be made by a central hub, which is a private institution with linking with various spokes, which can also be private peripheral institutions. So this actually can enhance the collaboration and contribute significantly to the notification, diagnosis, treatment, every aspect of the patient, of patient's treatment. This is basically what it is.
So, sir, as per you, even the Ayush doctors can be a part of such kind of model?
Yes.
Please remember that I can just tell you from my experience. There are states in India which we had gone as a part of the joint monitoring mission, where in fact more than half of the population goes first to an Ayush doctor or big Ayush hospitals, right? Now, I found those Ayush hospitals also having the program units, because the national program has tried to involve them. So yes, they become the spokes, and they are linked to central hubs, which can be a private or a government institution. So I've seen that on the ground, and yes, they can happen. They can.
Yes. So similar story is there in Mumbai also right now, where we all know Mumbai is like, the highest number of slums are there in Mumbai. And in Mumbai is divided in 24 districts. So each and every district, you won't believe, I'm not exaggerating over here. We have good 125 to 150 general practitioners, Ayush doctors sitting over here in each and every district. So we have such high number of Ayush practitioners sitting over here. And
it can be any healthcare provider. It can be any healthcare provider.
Any healthcare providers. Yes,
any healthcare provider.
Perfectly right. So the first point of contact, where they charge maybe just 20 rupees or maximum 50 rupees for their first consultation.
Absolutely.
So they are the first point of contact for any person in the slums, available over there even at night 2 o'clock for their patients. So these doctors were really helpful in our cities at least. What we did was, similarly, the hubs were being created in for example, there is a district, and we had just identified certain hospitals or certain chest physicians sitting in that hospital who were being trained as per the guidelines. So these health officers, healthcare workers or health officers or doctors sitting over there in the slums or in the peripheries over there, who were the first point of contact for their patients, they were being offered free of cost x-rays. They can give free of cost vouchers to their patients where they diagnose or suspect tuberculosis. Once if there is an abnormality on the x-ray chest, they used to refer the patient to the hub centers, to the chest physicians sitting in that facility, where the chest physician will confirm the diagnosis and initiate the patient on treatment. So this is spoke and a hub model, where all the patients from the periphery were being referred to the hub, who is providing the treatment appropriately as per the guidelines. The same thing can be thought of, such similar models can be thought of in different states. Wherever you feel there is a lack of doctors, you can just take help of any practitioners, train them. You can just make a provision, collaborate with some NGOs who can make available the x-ray facilities if they're missing over there. So basically, the idea or the point is just to throw some light, and then you can think of the scenarios in your states and cities and can come up with your own model, which will be helpful for your patients at your states and cities.
You will be surprised, Dr. Vikas, that in one of our slums, which is in one of our districts, one of the chemists actually took the initiative that since he found that the patients are visiting him for purchasing anti-TB treatment, he had some spare space left. He basically offered that particular place, a very small place, for the sample collection to the local district TB hospital. Now that's how all these small things can be started. But here the initiative actually came from that particular person who is not even a doctor. So these things actually we have to involve these.
Exactly. So that will happen only when you enter the shoes of your patient, understand their problem and their hitch, where the problem is lying. Is it the money? Is it the time? Or is it the availability of the doctor? So that we can, fix those problems for the interest of our patients. So it is not only one single model which can be replicated everywhere. I would come to Professor Thomas over here. I would need your help, sir. Sir, I want to know at Thrissur what kind of model is going on right now over there, and where you think, this model will be helpful for us also over here, sir.
Yeah, thank you. Before answering question, my sincere thanks to CCI for inviting me. And we have Dr. Shibu sir. So he's the expert in this. We have a STEP model in Kerala. and I have a center called STEPS in Amala Medical College. Here we have a single window for the TB treatment, whether it is pulmonary form or extra pulmonary. The cases from our department and all the department will goes to the STEP center. There is a medical officer there, and she has got a lab technician and the supportive staff there. So all our patients will be transferred to this STEP center. This is a system for TB elimination in private sector, sponsored by state government, and the patient will be notified to the government agencies, and the treatment will be given free of cost. But definitely the follow-up will go to the corresponding doctor who diagnosed the case. So in our experience, what are the plus points of STEPS? Because in Amala, we have a TB treatment, last 20 years, more than that. I joined in Amala almost 13 years ago. But the statistics wise, the diagnosis of TB has not increased from the year 2011 till 2023. So diagnostic efficacy not increased after the STEPS. But what all things increased is, one is drug sensitivity test. Like when Gene Expert was implemented, it is free of cost. So all our patients got drug sensitivity test for INH and rifampicin. That was a big milestone. But drug resistance is quite low in our districts. I think the total statistics around 40 to 45. So it's not a big burden. I have seen only 2 drug resistant cases. Yes.
Sir, sorry to interrupt you over here. Suppose if when the Gene Expert was been made available at your states over there, and before availability of the Gene Expert, so I just want to understand, was the diagnosis as per the clinical judgment over there on X-ray basis, or like whether it was a clinical diagnosis or whether there was a microbiological diagnosis before Gene Expert?
Yeah, we were doing sputum IV smear and culture. So if you take the statistics, we have only very less number of patients are more positive with the Gene Expert compared to the previous statistics. But the drug sensitivity we were not doing, but that was an extra advantage. But if you take the notification from our center, there is no increase after the STEP center.
Yeah, that's what I was trying to understand. Suppose if after STEPS, where you made Gene Expert upfront, where the Gene Expert, we all know the sensitivity is really good compared to the conventional ZN smear which we were doing previously. So what was the reason where the diagnosis did not go up? The diagnosis should have, as per the understanding over here, the diagnosis should have gone up after STEPS, involvement of STEPS.
Yeah, one thing I will tell you, we have more extra pulmonary TB rather than pulmonary TB. We have 60 to 70% of extra pulmonary TB. Okay. Our annual TB incidence is 200 to 250. It varies. Last 10 years, it's same in our center. So because it's extra pulmonary, the sputum yield, the AFP positivity will be less, and also CBNAT. Nobody is sending for CBNAT because it is done by the surgeon or the orthopedic people. Mostly they are sending to the histopathology department in formalin. So samples are really not available. That might be one reason we are not getting more positive yield after CBNAT.
Yes. So this is a very important point now that, we need to train our colleagues. That is very important. That can be done only after sensitizing them again and again, especially when it comes to general surgeons, surgeon fellows, and orthopedic fellows, where it's, formalin is a favorite for them. The way we use stethoscope, I don't know, they just use their formalin container. Any surgery, they just open up, remove, and just dip it in the formalin. I don't know what pleasure they get. So we need to sensitize our colleagues over there that please, if you're suspecting tuberculosis, divide the sample by 2, 1 in normal saline, 1 in formalin. Formalin sample for histopath examination and normal saline can be sent to your center for further Gene Expert, LPA, and DST, MG culture DST, right? So, sir, have you then started sensitizing your colleagues over there once you have recognized the problem over there?
Yes. We had last sensitization program 2 weeks ago, and they are very much surprised. CBNAT is available. why to send for that? We used to send only for histopathology. So it was a new information for gynecology colleagues, orthopedic colleagues, and surgery people. So they were the chunk of the extrapulmonary TB. Lymph node excision biopsy directly go to the pathology department. So now I think probably next year I can show you the increase in a gene expert.
I would be waiting for this, sir, and I'm very sure the person like you sitting over there will surely make it happen. Like, just be behind them, sir, and start sensitizing, training them. Please give them the knowledge about the fantastic algorithm which we have in our guidelines, so that the patient gets appropriately diagnosed and treated as per the requirement of PMD, the guidelines, right?
Yes.
Coming to you, Dr. Narayana, sir. Dr. Narayana is doing a fantastic job at Kasaragod, and I am really, he keeps on sharing many cases wherever, we just exchange our cases from Mumbai and Kasaragod. The extremes what we see in Mumbai and Kasaragod in our chat is very much obvious. Oh, Vikas, your patient, please, you are living in different country altogether, and I am in India. I am in Kasaragod, India. So, Dr. Narayana, can you please share your experience and your model when you're working over there?
Thank you, Vikas. Thank you, Shibu sir. And I think Dr. Shibu sir knows all the because it was under his direct mentorship that we were working for PPP. It was long ago, I can tell as a tale story. Long ago, Shibu sir was our WHO or NTEP consultant in Kasaragod. So we are very fortunate to have his guidance and his mentorship directly under him. So one of the models that was proposed and worked well was IMA RNTCP model, where IMA, that all of us know that there is a human resources is the biggest problem in the government sector. So through IMA, we appointed lab technician to the CBNet site. So that the work burden to the public lab technician was greatly reduced, and it helped to receive more samples from the private sector as well. So this has helped a lot in Kasaragod, and there is a lot of samples were started coming. Even we had got synovial fluid was positive for gene expert MTB detected. Then we had got a pericardial fluid. Then we got.
So just to understand, sorry to interrupt you over here. So you're talking about when you are sitting in a public sector and
Yes.
the samples are coming from the private sectors, right?
Yeah.
Oh, that's great. Okay.
And actually, I was both sides. Like I am a president as well. I am a secretary for 4 years.
So you made an appropriate presentation of your position over there, and just have guided all the
both sides
medical officers to send the sample at the public sector. That is very much important. I like that. Okay, so that's very important. We need to make up their own models. And you need to think that how you will be helpful for the society. Unless you have that spark in you, it's going to be very difficult and challenging to just adopt a model from other states. Sir, please continue, sir. Narayan, sir, please continue.
Second model which we introduced was our Kasaragod is a border district, having border between Kerala and Karnataka. It is like you can just 30-35. I mean, we have a. So we had like border meetings, like two districts, Dakshina Kannada and Kasaragod districts. We had a WHO consultants of both the districts. We had a DTOs sitting together and STOs of both the states. So this model also improved a lot in the private and public sector of both the districts. So this even I think we have sent the abstract of this study as well. And one of the PhD scholars is also doing the same study over how the standards of TB care has improved with the border meetings and border sharing of the experiences. So these are the two models. One is IMA NTP, IMA RNTCP model, and another is the interborder meetings and interborder things that has really helped a lot in the improvement in the standards of TB care for our patients in our district.
Great. So that means you made a maximum utilization of your position. You trained your colleagues and friends, and you inspired them to at least send the samples. I'm very sure the diagnosis would have gone up after getting referrals from all private physicians over there. And obviously, when the diagnosis goes up, automatically the treatment, the outcome also improves. The impact is already been seen over there. I will come to Dr. Anil Maske over here. Now, how you think, how you would like to inspire more and more doctors in your area? Because what I have heard in all the trainings everywhere, sir, private physicians don't like to come together or work along with government sectors. So I would like you to ask over here, sir, how would you inspire these doctors to get engaged with this such kind of PPP models and fight against this battle?
Good evening, Dr. Vikas. Yeah, as you already mentioned and as has been discussed, that around 70 to 75% of the patients, they primarily or initially they visit a private practitioner, may it be a private consultant, allopathic or Ayush practitioner. So I think repeatedly we have to sensitize and motivate these people. We have to take them in our confidence. And we chest physicians have a major role. I think private chest physicians or even in the public sector people, we have to go beyond our limits. We have to be in touch with these people repeatedly. Say in the last 10 to 12 years, we have seen the progress of NTEP. It has come up a long way ahead. Only because of this PPP model and contribution from both the public and private sectors. So I think sensitizing them time to time to be having a frequent contact sessions of say CMEs or training sessions, the updated guidelines can be communicated to them repeatedly and hammering them with even we have to think of showing them the gazette notification. We have to remind them that this notification is very must. We have a gazette notification since 2012 and it's very essential to eliminate TB by 2025. So I think these are the basics of inspiring these people. Apart from, say, increasing the DBT amount from whatever it is right now, that can be a crucial part as well. And Ayush doctors, as we all know, many fever patients, febrile patients, or presumptive TB patients, they seek help from Ayush doctors from periphery or even metro cities, like you already discussed in Mumbai also. Ayush practitioners, they are very important. So repeatedly sensitizing them or making them private TB care provider and thereby having a monetary, thereby communicating them that you may have monetary benefit also from linking these patients to say chest physician or a government or a nearby health facility, which can diagnose them properly and without losing our precious time.
Okay. So yes, training all our colleagues, sensitizing them again and again. Yes, I'm very sure we all are doing that in the field. But still, if we see there is a lack of such kind of partnerships or such kind of models are still, we have failed to replicate them all over India. So that means something somewhere we are missing over here still. And out of experience, I would like to add on over here, maybe we are failing to explain them or give them a crystal clear picture over here of the program, what program is doing, what we are doing, and how we would be helpful and get collaborated with the program. Because sometimes, when I never approached Dr. Balakrishnan, I never came to know that, yes, I could be a help for this field. I was just being told that if you want to get engaged in the public sector, you will have to get trained for under PMDT. It's like you can say certificate course आपके लिए जाओ. आप private में हो, आप एक course आप करके आ जाओ PMDT. I never knew what PMDT is. I never knew what PMDT guidelines are. So it was the first time when I went to Dr. Shibu Balakrishnan over there as a teacher. He just taught us the entire guidelines. He made us learn and understand how the program works. And until and unless we, take interest from our own self, it is next to impossible to attend any webinar, any seminar, or any CMEs or sensitization programs unless and until we go ahead and take a step and try to understand कि program क्या क्या दे रहा है और हम उसमें से क्या क्या avail कर सकते हैं. एक वो जो गैप हुआ है वो खुद ही हम अगर फिल करने की कोशिश करें तभी वो एक अपना मॉडल वहां पे तैयार होगा. मुझे ऐसा लगता है somewhere. I really, Dr. Shibu Balakrishnan sir, would like to again come to you. Sir, there are multiple models which we discussed over here right now. What you think, sir, which could be the better model, or is there any one single model which you think can be replicated everywhere in India?
Yeah, thank you, Dr. Vikas. What is the best model for marriage? We should have a bride, a groom, and we should have a ceremonious linking together of those people. Whether it is a religious marriage by a Christian marriage or a Hindu marriage or a Muslim marriage, doesn't matter. We need a bride, a groom, and their family. Similarly, the most important thing about a public-private partnership is that we need a private partner, we need a public partner, and that should be an equal partnership. There should not be a bigger partner and a smaller partner. That doesn't work.
Right.
So anything is based on equality, respect. So there could be multiple approaches to that. There may be some modalities. For example, there could be direct engagement. Direct engagement means that a district TB officer or a sub-district level TB officer just walk into the chamber of a private provider and invites him for partnership. Or the district TB officer invites him to a chat or a cup of tea, and they find their appropriate way of engagement. That's a direct engagement. Sometimes a direct engagement may not be possible because of the time constraints, because of the access issues. There we may need a priest. Instead of directly the groom puts the garland on the bride's neck. So we need a priest to link them together. The priest is an intermediary. So this is called a PPIA model, or later it's a PPSA model. So these are the two very important models. Then there can be various sub-models, like, see, the hub and spoke model, what Dr. Anuj was just speaking about, and you have experienced, Dr. Vikas, in Mumbai, is an example of such models. Like, you know, the laboratories have shown this model, the hub and spoke model. The Lalpath laboratory or DDRC SRL, they were collecting the specimens at the periphery and they're taking those specimens to the hub. Similarly, somebody is doing a basic clinical service to the patient at the periphery, and they find that a hospital that has higher facilities can be a hub. They can refer the patient there physically or virtually. Telemedicine is as an example for a virtual referral, virtual hub and spoke. Right. So there are multiple modalities like that. Similarly, there could be a paid model or a non-paid model. You know, when we try to have the STEPS model established, now you know more than 1,000 STEPS centers in this country. And when the STEPS model has been established, it was not based on any paid model. These hospitals only wanted to have the services of high standards to be provided in the premises of the hospital without referring the patient to a place where it may not be convenient for the patient. So they established a STEP center to keep the patients with them, but they did not accept any informant incentive or any other payment. So that's a non-paid model. And at the same time, there are paid models also. The paid models are very important because of a reason. The peripheral practitioners are not minting money. Right. Now, I have a very close colleague of me. You might have heard about Dr. R.V. Ashokan. When we tried to have a dot center established in his hospital, and we're trying to request him to provide free of cost services to the patients. What he reminded us is that, Shibu, it's okay, but I'm worried during February because there are only 28 days in February, but I have to pay my staff for 31 days, right? So we cannot ask for zero cost service or non-payment service. So paid services and unpaid services are there. So there are multiple models, Dr. Vikas, but the crux is that for a partnership to sustain, Dr. Radha Munje was very clearly giving the most important anecdote for that relationship, holding the hands of the patients working on a carpet. See, the patient-centric approach with an equality in partnership is the only model that works based on the mutual respect and a common goal. Anything else is just the same principle in different bottles, the same wine in different bottles. So that's my take. Over to you.
Super. Actually, I was going to touch upon this hospitals. You throw a light upon this hospital models. Yes, there is also one of the corporate hospitals in Mumbai, that is Hinduja Hospital, who is already working in this paid kind of model, where patients don't have to pay for their OPD charges, okay, and they have a unit running over there once in a week at Hinduja Hospital premises itself. The government staff, the corporation staff sits over there for some data collection, and they generate a PMDD number at their OPD itself, in their hospital itself. And similarly, we also have one of the private trust over here, Somya Trust in Mumbai, who have given entire hospital and who is giving services for all TB patients, entire, even for IPD facilities, free of cost. So patient don't have to pay anything, even a single penny from their pocket. If he has to get admitted to the hospital, he just walk in over there. If he's a PMDD patient, if the patient is having a PMDD number, patient can avail free services in that hospital. He can avail services for IPD facilities. Even drugs are being offered over there at the least chargeable, some nominal charges over there probably. But yes, the staff is being paid by the Somya Trust, which they get reimbursed by the corporations at the end of month, or maybe 3 months or 6 months, as per the MOU they have decided. So yes, there are multiple models which are running in the field right now. We need to understand the need. Again and again, the same statement. We need to understand the need of an hour, the problem in our field, where the problem is lying, where the patient is having difficulty, and then come up with your own model. And trust me, government or the program is, sitting over there, the red carpet welcome for welcoming all the models. If your model is genuine and patient-centric, or even doctor-centric in that matter, and sustainable, there's no harm in, accepting those models. Dr. Anuj sir, coming to you over here, you being one of the National Technical Expert member, would like to, give some knowledge to our private chest physicians over here. I'm very sure many chest physicians are willing to contribute for TB patients over here. Can you guide them in some ways that we are talking about different models over here? Suppose if I was a chest physician where there is no model in my state. There are many states I know where there are no private PPP models running over there. So if I want to come up with some model, whom do I approach? How do I have a model in my mind? I want to implement that model. Sir, can you please explain me that whom do I go and share my idea? Whom do I ask for a contribution or collaboration, sir? So that this model, if it is a good model for our patient, some ideas or some, yes, sir.
Okay, Dr. Vikas. So the thing here is, now first thing that is important is that any such model, any model, please remember it will never exclude a DSTB patient or a DRDE patient. It has to be for any TB patient. Please remember that.
Yeah.
And secondly, and if any physician is interested in collaborating in a PPP mode, please remember these steps. That first of all, identify what particular healthcare needs are there in the area. What type of population you serve? What is the need? What type of support do your patient need? Contact your relevant public-private health authorities and organizations, especially the district TB officer. You want to collaborate with the program, you want to support the patient in ensuring that he gets rid of his disease and stays disease free. Please remember, sustained treatment success is the goal, is the ultimate goal. So please establish a contact with the particular provider, public health provider, or a public program officer in your area.
Okay.
You have to discuss with him your goal. He will tell you the responsibilities, you will tell him the responsibilities, and then discuss your resources. What you try to understand, what resources are available in the government sector, what sort of help will be available to your patients, what will be the cost, and whether that patient will be permanently lost from him. Obviously, if I am a private practitioner, I'll be saying that this patient can come to me every 15 days. Now suppose this patient moves on to the government sector, then it will be a sort of a loss of a patient to me, sort of a loss of income to me. The public sector person will assure you that no, you can actually, if you want, the patient can keep on coming to you if the patient wants. Now, at this particular point of time, now since you have understood the shared goals, the responsibilities, and the resources, now then decide on a clear operational plan. Now, there has to be a very clear operational plan, and then define the roles. What will you do? What will you expect from the program? And how will the program help the person? And then how will you help the patient? And how will you ensure that the patient comes to you, or ensure that the patient is taking the right treatment, following up the follow-up protocol, and then even post-treatment also he is continuing to remain disease-free. Number one, this is only the patient.
Right.
Please remember, he has a family. Please remember, he has a family. So if the public sector person will also be ensuring that the patient and his families are linked to the various schemes like prophylaxis, like basically all the TPT model, like the Poshan Yojana, all these government schemes. Now, basically, then all these things, once you start implementing the model, please keep on monitoring the progress mutually. It has to be you are not the only person who will be monitoring the progress. It will be the public sector person, the doctor, the DTO who will also monitor the progress. And if required, then you start making the necessary adjustments. This is these are the basic steps that you will actually require to follow to establish any model that you want. It's just that you have to contact your DTO and tell what exactly is in your mind.
Exactly. So, sir, will it be a compulsion for me as a private physician to go and attain some sort of PMDD trainings the way I did those years, or would it be?
I think at some particular point of time, a refresher or a training will be a bit helpful, but you actually have to know. Suppose I am a private practitioner, I actually will not be required to shut down my clinic and go there for 7 days or 8 days or 10 days. I have to know what is the protocol of investigation, what is the protocol for treatment, how to follow up the patient, how to ensure that what sort of a sample is to be collected, the basic counseling of the patient, what all do I counsel my patient for, and then how do I ensure that the patient is taking the treatment. To answer his basic questions, it's not a 7-day training. It's something that can be discussed over a cup of tea or 2 hours. There are standard charts that are already there. There are standard health education charts that can be easily put up in your clinic and explain to the patient as and when he comes to you for a visit.
Exactly. I think now, Dr. Shibu, please correct me if I'm wrong. So those were the days where, 7 days or maybe 5 days were the training sessions for PMDD guidelines, PMDD training sessions. And where I still remember shutting down my clinic in those days and attending the training over there. I'm sure many of us won't be able to spare so much of time. So now, as Dr. Anuj sir have mentioned about just training on a cup of, say, coffee or a tea also. So is there some official training, sir, just for a day where a private physician can just approach to the district TB officer or city TB officer and ask themselves to get trained under the guidelines just in a day and come back so that he will be helpful for the program?
Yeah, so thanks, Dr. Vikas. So this is not a clinical training, right? This is a programmatic management training. It's how the program is managing drug-resistant TB. That's what is being trained. It's not about how to diagnose TB, how to diagnose drug-resistant TB. You are the experts. Who is going to train you on those kind of things? This is about what the program does and how you can make use of those opportunities for the benefit of your patients. That's the only training being given there, right? So now that is available online for online training, like PMDT online training is available. You can log on to Swasth eGurukul and then self-train yourself. That's something available, and you can have a certificate printed. That's one thing. Yeah. Okay. It's up to that level. But still, I would suggest to have at least a couple of hours to be spent with the district TB officer. Right. And the district DRTB coordinator, because they can really help you with the customized or personalized packages. It's not that simple, what is there in the program kind of thing. See, in Mumbai or in Hyderabad or in Patna, what is the best approach for PMDT and in our context? That can be done by the district TB officer and the district DRTB coordinator. So that is physical. Anyone else can have online.
Yes, ma'am, please come in, ma'am.
Yes. I would like to add what Shibu has said is that usually what is done is that you look at the specialty of the doctor. So, for example, a microbiologist is to be linked for availing services. Equally important are the samples which are coming from practitioners who are not linked to the program. So I'll quote an example, like many people ask me advice over the phone whenever they come across a few cases of TB, where they would come across some speed breaker, I would say. So if the doctor tells me that madam, directs में भी positive था, culture भी positive था, follow-up में positive था, and then I ask him, then what did you do to the culture? So the next answer is CBNAT, and that's the end. So I feel that here, not only the consultant, can you hear me? Not only the consultant, but it's important to let the microbiologists know the importance of those positive cultures, which should actually be processed for first line and second line LPAs, and then DST if needed. So first and foremost is they have to preserve the culture. So these are the different type of linkages and trainings which, or say rather I would say sensitization needs to be done. The first one which everybody talked about was putting the surgical sample in the normal saline. That is the first thing which is very important. The second I would say is that wherever the sample goes, and if the cultures are positive, because in the program, the cascade is inbuilt. In the private sector, there is no cascade built in, so the, what is the advantage as well as at the same time limitation in a private practice is, I would be bold to say that money. So there is money available. So a number of investigations are asked. And then there is a time when the doctor doesn't feel that more amount should be spent once the diagnosis is made, and thus money becomes its own limitations. So I feel whenever such conditions arise, the best thing would be that the practitioner should be linked to the public facilities where all these facilities are made available. Importantly, when you look at other strengths and limitations are, the strength is that the practitioners have loads of experiences of patients which are coming to the private sector. See, everybody's mentality is a little different. Though everybody wants a good diagnosis and good treatment from the doctor, a mentality of a person or a psyche of a person who goes to a private practitioner may be a little different, which only his treating physician or practitioner understands. But at the same time, the limitation which comes of such experience or a long legacy of experience is confidence. And sometimes they are on overconfidence. So I have come across many surgeons who say, "Humne abdomen dekha and it was studied and the diagnosis was TB and they closed it." But then it is very bold of me to tell them that, sir, we appreciate your confidence and we pay respect, but it would have been wise to take a sample to see whether this is resistant at the same time, as well as your diagnosis is supported. We don't object, but it is being supported if the cultures or CBNAT are being done. So I feel that what Shibu has been saying about, and you were talking about training, we have to look at each specialty, what is to be offered to them and what is needed to make them to be linked to the program so that ultimately the patient is benefited. They have to understand that extrapulmonary samples are very, very precious. So once you remove a lymph node, you cannot create a lymph node to take second biopsy. Right? Yes. So they have to extrapulmonary samples are very precious. They are scanty. So they need to be preserved. They need to be sent. I'm lucky to have few people around me in the private sector also. And whenever the sample comes positive for TB, the radiologist tells me that, "Madam, ye difficult to do CT guided biopsy tha from the abdomen or from the lungs." But he makes a point that each of his sample goes for culture apart from the routine investigations that they do. So I feel that these are the people who should be our, they should be our musketeers. These are the people, not you and me who are already in the program, but somebody who is not in the program, but always does it very judiciously with all respect. And then once in a while, he does get positive reports for TB in 100% positive malignant case, which was clinically suspected by the expert. Right. So I think there are few people out who are really doing a good job, and they should be linked to the program, and they should be the people who should be conducting these short sensitizations or trainings.
Sensitization program, definitely yes, ma'am. We all chest physicians need to train our colleagues, our fellow workers. If you find any problem in the field, you can just rectify them in a polite manner, in a different way, which is acceptable way for everyone, so that they don't repeat the mistakes. Exactly right. So coming back to the point, so suppose any chest physicians is willing, to join or get collaborated with the program and need to know that what to do, how to do in their area. They just need to knock the doors of district TB officer. You can just explain them that, see, load in my area, in my ward is really high. There are a lot of n number of TB cases which are going clinically diagnosed. Maybe I would help you all in a microbiological diagnosis. Yes, I have already gone through the certificate training, online training, or PMDD training, as per Dr. Vijayan has already mentioned over here. Sorry, Dr. Shibu has already mentioned over here. Can you please repeat the site, sir, for online training?
E-Gurukul.
E-Gurukul. So everyone can just make a note of this. E-Gurukul.
Yeah, Swast E-Gurukul. Swast E-Gurukul.
Swast E-Gurukul.
E-Gurukul.
Yeah. So it's Swast E-Gurukul, where you can just train yourself, get upgraded under PMDT training. You don't need to spare 7 days, 5 days, 3 days from your busy schedule. It may be of some, how many hours, sir? The training would be of?
They can pick up a module of their choice.
Okay.
They can pick up a
modular training. Modular training.
Modular training. Great. So it's a modular training where you can train yourself. Once you are ready at your part, just sit in front of district TB officer on a cup of tea. चाय पे चर्चा होती है. सर ने, अनुज सर ने ऑलरेडी बताया है. चाय पे चर्चा करते करते खाली बोलिए कि बाबा मेरे यहाँ पे टीबी बहुत है, मुझे टीबी में काम करना है मेरे पेशेंट्स के लिए, कुछ मैं मेरी तरफ से कर सकता हूं तो मुझे बताइए. District TB officer may just judge your knowledge. There is obviously no one to judge you, but for the betterment of the patient, you may tell him something, you may explain him something. If the things go smoothly, you all can come up with some good model which would be really helpful for your patient, and then very soon this small thing can be bigger, bigger and bigger. You won't even come to know when this SIP had turned into a big saving and investment for your patients and your ward and your country. So just rectify me, Shibu sir, if I'm going or missing some point over here. It is very important because many private chest physicians, they are willing to contribute, I'm very sure, but they don't know whom to approach, how to approach, where to approach. So there are no guidelines for how to approach. In guidelines, they have mentioned that yes, we need PPP models. So these models can be made by our own self, but it should be genuine as per the guidelines, as per the training. Trainings can be self-trainings under the PMDT. PMDT is nothing but programmatic management for drug-resistant tuberculosis. It's just to understand how the program works. So on Swast e-Gurukul, you can understand how the program works and then just fit yourself wherever you can fit. And yes, the model is ready. Dr. Narayan, Pradeepa Narayan, I want to come back to you again, sir. You being a president of IMA. So, sir, were you knowing about this Swast e-Gurukul before?
No, I am present, I was not knowing, but as a part of the government, I am knowing.
Yes. So now, would you think, sir, will it make some change or difference when we just, flow this idea of getting yourself sensitized or get trained by Swast e-Gurukul and get more and more physicians over here? Yes, you have already sensitized them for sending samples for Gene Expert under the program algorithm so that at least they get diagnosed. But now how more we can engage them?
Yes, actually, the training should go more modernized. Actually, I got a training on how to make modernized trainings in Hyderabad last, I think, 1 month back. So our training for the doctors, we can make it more modernized. Modernized means it is not something different, but using the modules. How exactly even if I give you the training in Kasaragod and if you give in the Mumbai or somebody giving in Assam, everything should be in the same lines. That is how it can work. The e-Swasti Gurukul is actually very good. Actually, I was experiencing it from last 1 month only. I got 2 trainings in the e-Swasti Gurukul. One is PMDT training, another one is the STS, STLS training. Both modular training I got through e-Swasti Gurukul only. So it is working actually very well. But we need more trainer TOTs and we need more such modular, modernized modular trainings. Then only we can have a good.
I agree to you, sir, that online trainings are trainings, but they are just for they have their own limitations. Unless and until you sit in front of an expert and clarify each and every doubt which you have, it is not possible with the online trainings. I do agree with you, Dr. Thomas, sir. Still, you also feel that is there some need of engaging more and more chest physicians with such kind of models? And what step now would you think you would take at your state or city over there, sir? After listening to such kind of discussions over here.
Yeah, in Kerala, I think steps is going in a beautiful way, and it has every quarterly assessment of each step center and assessing the problems. Like I told you, 2 weeks ago we had sensitization to our extrapulmonary colleagues. So they are now motivated to send the samples for CBNAT and all. That is one way. Other things we are during the World TB Day commemorating in association with IMA, we organize so many programs for the doctors in and around Thrissur in association with our pulmonology society over there. I was the president of pulmonology society last 3 years. So we organize in such a way that the program goes to any basic doctors who is dealing with in and around Thrissur. So I think that is one thing. And second, the STEPS program is actually trusted by the the private doctors as well. And patients are also very comfortable that way. So I would say this program is done a wonderful job in Kerala, in my experience last many years. And if you ask my personal opinion, I think this program is good for Kerala, but I don't know whether it will work in other area of India. That we have to see.
Sir, under the STEPS program, what is going on right now, just to ask and understand, do you have all the facilities under one single roof, or does the patient need to go to some different departments or different say facilities to avail some services? Like,
Yeah, actually, after diagnosis, this patient will go to the single window program. That is, that medical officer over there will arrange everything, and it is done in a in a very good way that a patient never say any complaint against the program existing right now. So we are also very comfortable with this association, just like Shibu sir was telling, no. Mutual trust which is happening, and our DT also in a very good relation with us. So many times we involve with them, the program people as well. So we don't feel any difference. Initially, when 20 years ago, when I was practicing in private hospital, we could see the difference. Private sector, we are giving daily regimen, government sector thrice weekly. So I am not happy with that. I was trained in JIPMER where they give a daily regimen, though the program is thrice weekly. So we just followed because we were done training in JIPMER. So I continued that. Then the program people tell me that you should refer. I told them I will not refer because I'm comfortable with this regimen. But such kind of conflicts are not there currently. So I think the Kerala model is a little good in that way.
okay, that's good. Dr. Anil Maske, sir, coming to you, at your institute, sir, I just want to understand, do you have a one single department and all services which are available in that single department, or whether the patient needs to go to some other departments for submitting the sample, getting diagnosed, then fitness, then blood tests, investigations? Like how is it done over there, sir, in your institute?
Dr. Vikas, I actually work in a government medical college, so things are very good at my place. Everything is under one roof. We have microbiology backup. We have a good pathology backup as well. And I have, since last 5 to 6 years, with the inception of CBNet, incorporation CBNet, I also have contributed telling my surgical, orthopedician, gynec, and everyone, my colleagues, that we need to have tissue diagnosis of particularly had this tuberculosis, extrapulmonary tuberculosis, and we should not be starting ATT empirically. So I don't remember when I started empirical ATT in last 5 to 6 years. So scenario has been changed. There is not much any problem in my institute because we all have all diagnostic facilities under one roof. Even we have
admission facilities. Even the admission facilities?
It's a medical college, so we have a DRTB ward, MDR ward we have. We cater a good number of MDR patients also, because many patients who are daily wagers in Pune, Mumbai especially, and when they get sick, we see these patients from, we referrals from these patients, and they are living in their villages. So I see many patients who are being diagnosed by my colleagues like Dr. Vikas, you yourself, or Prajay Lunia. So I quite see such patients who are there in metro cities, and now they are having MDR TB, and now they are at their town. So okay, that much in the institutions.
Government both private as well as
Recording in progress.
Audience view is post now. Everything is fine. Should I continue?
Please carry on.
Yeah. So, so even after sitting in this position right now, when the patient get diagnosed as DRTB, and when I ask the patient to come and meet me in the public sector for that one single day for initiating the patient on second line drugs, where we still don't have an access to the newer drugs in the private chambers right now. Sir, what do you think? How can we overcome this challenge, sir?
The best way is to link up. Actually, I can give you an example in my city, right?
Okay.
For one of my very dear friends, who is a part of who is working in a very large chain, Fortis group of hospitals. Now, one of the hospitals has opened up a DRTB, private DRTB center, and the moment they diagnose the patient, the program ensures that their patient actually are getting all the latest drugs, and the patients are following them up. Patients are getting follow up from them only. It's very clear, and that is actually the shortcut. Link up with the particular district, and the district will just assign a MOU with the district or the program or the state, and you can actually ensure that your patients will get the latest particular drugs. You see,
how do you sorry sir to interrupt you over here. How would you take care of the regimen making over there, like the adherence to the guidelines over there, sir?
Well, that is once again the same thing. The MOU will actually be covering all the aspects that the private DRTB center or the private provider will ensure that every single follow-up criteria, every single regimen that is there, that has been approved in the PMDT, is followed in the private sector, and that is actually being done. Now, these things have to be are bare minimum for the collaboration to happen. Now, this is something what we can say is a requirement. That the timely follow-ups, ensuring the right drug, ensuring the right regimen, ensuring the right dose, and ensuring the right follow-ups.
Right.
So that's what it is. So you can easily get access to the newer drugs provided you have an MOU with the program, and you can ensure that yes, your patient will be getting the newer drugs.
Right.
But simply you cannot prescribe that drug, and the patient goes. If suppose a private practitioner is writing a drug, suppose he writes Vadakkan, he knows that the patients these particular medicines will be available in the government sector, and the patient will be coming to me. And at that particular point of time, then I'll actually have to see all those things, whether the patient was diagnosed correctly, whether the lab from where he has received his diagnosis is covered under EQA, or all these things that are important, or are the tests or the machines going under annual collaboration or calibration. All these things have to be seen. So the point is, if the MOU is signed with the program or the state, these things can easily be taken care of.
Right. So again, the point is the same thing. What I wanted to make a point over here. But before making my point, I come to Dr. Shibu sir over here. Would it be a good idea to give an access of these newer drugs to all private physicians, who has a good practice of tuberculosis?
Yeah, so thanks, Dr. Vikas, for that question. Of course, the newer drugs or any new technology that comes to the healthcare, whether it is a test or a drug, that's to be made available, universally available. That's what's called universal access to TB care, right? If the care is not accessible to those who are seeking care from the private sector, then that's not universal access to TB care. So all of us, I mean, the national policymakers, the technical supporters, and the partners all believe in universal access to TB care. The only issue here is that for somebody, the newer drugs, so-called, they are not newer anymore. These are at least 10, 15 years old. These are very costly.
Yeah.
And potentially that can cause different types of adverse reactions. So those people who are using those drugs, deploying those drugs to the patients, should be very clear about how this can be given in a program modality and how to monitor them, how to ensure adherence to treatment. So these are some of the basic requirements for the private physician who would like to use these drugs. Right. So those private physicians, including pulmonologists and any extra pulmonology surgeons who are who would like to treat the patient, DRTB, pulmonary extrapulmonary TB patient with newer drugs, can easily access this if they have a training under PMDT and if they have a in-house or external panel of specialists to do a pre-treatment evaluation and do a patient monitoring till the end of the treatment, and also give an undertaking that we are going to use this under the programmatic guidelines. If that can happen in the form of an MOU, of course, the private physician can access and take it from me and Dr. Malik Parmar. We are committed to provide that access to all the private physicians who want to use this drug with the support of the program.
Exactly.
Just this
is what I wanted the clarity upon. So, many chest physicians feel, what's the use of the program? They don't give us the access to the newer drugs, the so-called bedaquiline and delaminate. And then they talk about the, referring the patients to, or rather, elimination of TB by 2025. So it's not that program don't want the collaboration of private chest physicians. It is just that they want it in a right way to happen. Things cannot go hasty or haywire over here. There is no chance of creating or augmenting resistance the way we already have learned a lot from our past and the history. Right now, we don't want to repeat the history over here. But equally, we are ready to extend our hands for this good collaboration in an appropriate way. Small step, train yourself, e-swast e-Gurukul, train yourself for PMDT guideline, PMDT training, sit with the district TB officer, talk to him, have a word with him, attend one single physical training, at least if possible, before starting this new collaboration, so that there is no chance of any doubt in your mind. Just get clarified with the thoughts of how program works. And then you also can have access to the newer drugs, provided you prescribe or you contribute only as per the guidelines. That is very important. We just can't sit over here and make 3 different regimens for a same single case. We can't do that. There is no scope of accepting different regimens for one single case. No, which was been proven in Mumbai right now over here. When there was a study, a small study was been done. One single case had multiple different regimens, that too with the chest physicians over here. So that was the point, that was the point which was being made, that we need to be on one single same platform, follow the guidelines. And yes, we can get access to anything and everything in an appropriate fashion and appropriate way. So it is not only having access to the newer drugs, it can be applicable right from diagnosing tuberculosis, investigations, then suspect of TB patient, getting it confirmed, diagnosing as tuberculosis, getting him evaluated before initiating him on second line drugs, and then even providing him the newer drugs as per the guidelines. This is what we have right now in the field. So it is just that our own interest, where we need to understand where we can contribute for this program and for the betterment of patient. I think this model can never, fail. This is what I think, maybe. Dr. Munje ma'am, when there are so many models in field right now, still why you think chest physicians are, what is the hesitancy amongst chest physicians? Why they still don't join hands in the program?
If I may add few of the things, and which is my experience with my colleagues.
Yes.
The thing is that it's not that they don't believe in program, but the earlier hesitancy कि हमारा patient हमसे निकल के private में या public में चला जाएगा, like losing their own patients, and the patient does not come back to them. It has been there earlier, which does not exist now, because the program itself is approaching practitioners and giving them opportunities to link at various levels. In fact, I forgot to mention, and many people haven't, that even your patient doesn't have to carry the sample, just a call to the program, and we have linkages where the sample is taken to the either the IRL or the center which has been linked to the program and has been endorsed by the program. So lab facilities are provided. So that is not there. Now what remains is that there are still, everybody still likes to have their own opinions about what is to be added. Even if we keep on advocating that do not add a single drug, they feel that by linking, their freedom is no more with them. That is also one of the issues. And equally important, I don't want to blame, but I want to bring this to the forefront, that when we go out with the facilities in the program and we tell something, it's like in Shibu's word, when you get married, you have taken so many vows to be followed or to be fulfilled. But over the years in any marriage, we all know that very few of them we stick to them, and many are either forgotten or taken for granted. So the same thing happens when there is a public-private mix. Like, for example, now I said that everything is done and the sample is being taken and it's given to the laboratory. But then the practitioner doesn't know whether the sample has been received properly or not. One. Secondly, it has been processed or not, and what are the results? Because now we have decided that the results would be put up at the next portal. But then who takes the responsibility of looking at the portal and letting the doctor and the patient know what are your reports? People are used to getting a hard copy of the report, which is like we are practically done away with, or even if they come very late. Then secondly, when we tell them about the newer technologies, like we say that the CBNAT reports are turnaround time is 2 hours, and then LPA, the reports turnaround time is 2 days. Many times either we fail to disclose, or even if it is disclosed, they are not taken with what is attached to that. That even if the turnaround time is 2 hours, you may get a report anytime between 3 days to 7 days. Or for even LPA, it may take longer than that. Then they do not understand that if the sample sent to the laboratory, if the direct smear is negative, the laboratory is not going to process the sample as it is for LPA. They would first do a culture, which would take somewhere around at least 4 weeks. And after that, the LPA is done. So there is another 2 weeks. So they expect miraculous diagnosis and a fast forward workup with all the facilities and things we have come up in the program. However, turnaround time and receiving reports are two entirely different things and may take a longer. So I feel that we need to continue with the dialogue, and communication is, I think, very, very important
all this
for
will
the
get
private
clarified in the
practitioners.
training programs, whatever you do, the PMD trainings. That's the reason
Yes.
we do PMDD trainings.
Yes. And then the third thing, which I'm coming now, is equally important, are the logistics in the laboratory. So many times, whatever may be the reason, I'm not trying to put a blame or put it on somebody's head that why this has happened. We just have to accept that जैसे हमारे घर की बिजली चली जाती है, कभी कभी पानी नहीं आता है. Even if you are living in a large housing complex where all amenities are there, a time comes when something doesn't work out for you. Similarly, even in laboratory, there may be few logistic issues. Sometimes the cartridges may not be available. Sometimes LPA strips may not be available, or whatever is needed. And the procurement gets delayed. Or, the consumables have been dispatched, but they are yet to reach. They would reach, then they are counted, they are, verified. Then they are brought into the functioning of the laboratory. So, what should I say, that behind the curtains also there are many activities going on which may get delayed and it then sends a wrong message कि हमने sample भेजा लेकिन 2 महीने हमको पता ही नहीं चला, and they lose hope. So I believe that whatever, be honest. If your laboratory has not processed, let them know that the sample has not processed, but let them know that it is preserved.
So suppose if the reports would have come on time, ma'am,
Yes,
and
yes.
if they would have had proper knowledge that yes, this report is going to come within 5 days, LP is going to take around 3 weeks, and DST another
Yes.
45 days total.
Yes.
Still, I feel there are some hesitancy amongst the doctors who still they are not willing to join the program. Now, what do you
Yes.
think? Why?
See, these people would believe only if they experience it. मेरा खुद का ये मानना है कि like unless you taste it, you would not like it. So that is what is important. आप आपके एक patient के लिए करके देखिए. If you are not happy, if something goes wrong, communicate that this is what has gone wrong. This is what does not appeal to me. This is what is not favorable for my patient. I'll quote an example from my own, clinic. I mean, I don't practice in my hospital. One of my relatives for extrapulmonary TB was put on anti-TB. After 8 days, I inquired her, do you have any side effects with the drug? And she said, मैंने अभी तक वो दवाई नहीं ली है. So, but I told her that, see, when I referred to you, I clearly instructed my PBHV that the medicine should be handed over. Whatever is the issue, I will take a follow-up on my own. Then she told me that, मैडम उन्होंने आधार के साथ बैंक का पासबुक का कवर मांगा है. So, because the counseling was not done, that this is needed for what? Everybody now has either a zero balance account, whatever are the different schemes of the government. Everybody has an account. But they thought Aadhaar bhi liya, bank bhi liya. So are they going to look into something like IT or anything else? So they were not told about Nikshay Poshan Ahar Yojana. Then I told them, don't worry. If you don't want that money, I don't know whether there is a system to refuse, but it is mandatory on the part of my people to give you that money because it is DBT. If we don't give, we are answerable that out of 100 patients, 80 लोगों को ही मिला और 20 लोगों को क्यों नहीं हुआ DBT. We are answerable at each point. So we need to counsel everybody, like patients in the public, patients in the private. And I feel that if the practitioner know that their patients would be given this, all patients are not affluent in private practice, but if their patients are getting benefited, it is another add-on good publicity for that doctor. कि हम इनके पास गए थे, we got anti-TB free, we got investigations free once the diagnosis was made. And now we are getting 500 rupees bonus, which takes care of any other small issues. Like they may go to a practice. It is given for nutritional purpose. But then money is theirs and we don't know how they might even use it for another investigation which is needed if they don't need it for supplementation. So I feel that practitioners should come out of their hesitancy.
Right.
I personally feel that they should be linking to the program. इसके 2 फायदे हैं. आपके पेशेंट को जो बेनिफिट मिल रहा है, जो प्रोग्राम को बेनिफिट मिल रहा है वो तो मिल ही रहा है. बट आपका जो बर्डन है, which you have not been doing, you are not doing a follow-up of your TB patients. It is getting done automatically. And at the end of treatment, you yourself know what has happened to your patient. So this is an added advantage to the practitioner apart from the good publicity he gets by offering free services.
Exactly. So definitely,
may I add one point?
Yes, sir.
Yes.
Please.
Yeah, actually, I used to tell my patients that you have to show your bank account and definitely some amount will be there. This is part of program, so they are happy.
Right.
I think it's better from our part to just brief about the program.
So basically, counseling is the thumb rule for each and every positive or better outcome. We need to counsel our patients appropriately. Let it be treatment, let it be diagnosing, let it be awareness, let it be selection. Whatever, counseling has play a very key role over here. So it's already 10 p.m. In the matter of time, I think we'll have to wind this session.
Plus, you have to announce logins. We have around 1,000 plus. So a big
wow.
big congratulations to team of CCI.
I really hope and I pray or I request to each and every physician over here who have been present to this webinar, kindly go train yourself, get collaborated with the program. Your patient, your ward, your city, your state, your country will surely get benefited. Trust me for this. You need to have some patience for betterment at each and every step. Before we wind up, I would just like to have one small, quick take-home message from Dr. Narayana Pradeepa, sir. The last few words.
It's always easy to collaborate with the collaborative and do work together, be united, and we can fight the TB.
Exactly. Sir, Dr. Anuj, sir.
Let's face it that TB cannot be eliminated by just one organization or one wheel of the healthcare alone. It has to be both the wheels. It has to be both public and private. Otherwise, I'm sorry, we will be failing. So please, at this particular point of time, it is for the interest of the country that it is required.
Yes. And if there is NGO entering over there, would be much more a better thing, private, public, and an NGO-based partnership. Dr. Shibu Vijayan, sir. Sorry, Shibu Balakrishnan, sir.
Thanks, Dr. Vikas. So, I always like to remind everybody that there is no private TB bacillus and public TB bacillus. Yes. There is no public TB officer and a private TB officer. Right. There is no private patient or a public patient. There is a patient who is affected by TB. Curing him, healing him is the responsibility of all. That's why we are partnering together. There's a chat, there's a question in the chat that what change you would like to suggest in the public sector. Obviously, the national TB program managers and the public health authorities have now really changed their mindset to have that equal relationship with the private. At the state level, it is equal relationship. At the district level, it is equal relationship. Whereas we have to move ahead by engaging our staff. It's not the doctors. It's the staff who have to change now. The TB staff, the public health staff, they have to accept how the partnership works in the field. So that is one thing I would request all of us here in this webinar to help in changing that attitudes of our staff, the public health staff, working for not only TB, but also for universal coverage, healthcare coverage. That's it. And thank you so much for inviting me to this webinar.
Thank you, sir. Thank you, sir, for being over here. Sir, Dr. Thomas, sir,
actually, we are telling about the partnership. I agree with the Shibu sir. Just like PMDT, this is a pre-marital course for private doctors. Something like how to deal with the private doctors by public health doctor also should be there. That should be a private doctor dealing program. Can be there modules so that this clash and unnecessary ego issues can be solved. This is my message. To build up the private and the public, cooperation in the TB management.
Exactly. Radha, ma'am.
I think Dr. Vikas, everybody has said it, and I always feel that everybody, see, this is a great mission, and it's not for you, me, or our patients around us, but it is for next generations to come. That we are trying to do something good at the right time, which is much needed. We have already set our goals and we have an ambitious plan. So to reach there, rasta kaisa bhi ho. It may be tough, it may be smooth, it may be ready-made, or you may have to make it on your own, but we have to reach to that goal of TB elimination, which is much needed for our generations to come. So I think we must join hands at each turning, at each point, and for the betterment of everybody.
Dr.
One
Anil
thing,
sir.
because just one thing,
Yes.
we have not taken audience questions, but when we looked at the questions, most of the things have already been covered.
It's
So
been covered.
we must be thanking Dr. Golo Srinivasan from Telangana, Dr. Ashok Wani from Jalgaon, and he has asked a question on PPT, which I think we have already had a webinar, or we may hold another webinar. And then there has been Sushma
Dr.
Dugat
Sushma
from
Dugat.
Nashik and Lanjewar from Nagpur.
Yes.
So we have to thank everybody who has logged in and put in
Dr. Anil
questions
is
also.
left. Dr. Anil is left for his last take home message.
Is it?
Yeah.
Right.
Dr. Anil, I think he's out of network. Fine. I think we'll just wind. Okay.
Hi, sir. Hi, sir.
Boliye, sir. Sir,
Yeah.
last take home message, sir.
Sir, we have to engage and we have to go hand in hand with public-private practitioners. That's the way forward, I think.
Yes. So, yes, each and every practitioner can be super helpful, can be very much, can make a lot of difference for your patient, your community. It is just that spark should be there within you. No program can give you a spoon-fed model. You have to make your own model. Just try and understand where you yourself as a Lego can fit in a perfect Lego so that this can become an empire. You can make your own empire in your own country for the betterment of people, patient, and your own country. And let us just try to eliminate this TB before 2025, or at least till 2025. That would be a genuine request to each and everyone, one and all. Fighting his battle against single sector, not possible. Each and every one will have to join hands together and be truthful to ourselves, guide, educate your patient with whatever is right. Let it be cost, let it be investigation, let it be drugs, let it be duration, let it be side effect. Please take some extra efforts to counsel your patients so that we have a better outcome and the disease is gone soon from this country. At least there is a dip which we see very soon. And by this, we will just end this session over here. Thanks a lot. Thank you for being with us. Thanks for all your patient listening. And thank you, entire panel, for being along with us and accepting our invitation. It was really wonderful to be along with you also.
Thank you, Vikas.
Thank you.
Thank you, everybody. And thank you, CCI, for holding such a wonderful webinar.